So our speaker today is Dr. Edward Hoffer, and he's had a frontline view of what's going on in medicine for over 45 years. Okay? He's practiced internal medicine and cardiology, and he's going to talk about what he's learned with all that experience about how the medical system works in some ways and other ways in which it doesn't work. And he'll also have a few suggestions on how to improve it. Dr. Hoffer got his undergraduate degree from MIT. He got his medical degree from Harvard, and he did his residency and fellowship at Mass General Hospital. He's held a number of academic faculty appointments at Harvard, at UMass, and at Boston University. And he's also had practicing appointments at numerous Mass hospitals. For example, in Boston, he's practiced at Peter Brigham, Beth Israel Hospital, in Boston Women's. In Metro West, he's practiced at hospitals in Worcester, Natick, and Framingham. And in Burlington, he's practiced at the Leahy Clinic. And if just practicing medicine wasn't enough, he's also authored or co-authored over 80 publications, including 8 books and dozens of refereed journal articles, many dealing with applications of computer technology to the medical profession. So he is still not fully retired. He works half-time still at Mass General Hospital in the lab of computer science. And so without any additional introduction, I give you Dr. Hoffer.
George, thank you very much for that kind introduction.
As George said, I've been around the block a few times and have noticed 2 major trends in the practice of medicine over the years I've been doing it. On the one hand, the scientific, technological progress has been amazing. I mean, when I was an intern, if you came into MGH with a heart attack, we basically put you to bed and watched you. And one of the big breakthroughs is when we let you go home at 4 weeks instead of 6 weeks. Nowadays, of course, you show up in the emergency room and you get whisked off to the cath lab, you have the artery opened up, and you go home the next day. Almost unheard of. Number of other things. At the same time, the trend in the delivery of healthcare has gone from one of being a caring profession to one where the bottom line is what rules. You know, in today's medical care system, patients are not happy, doctors are not happy, nurses are not happy. The only people who are happy are the administrators, who are getting fat and rich. And I think, one excellent example of the kind of the state we're in with medicine these days is this, the front page of the Boston Sunday Globe from, last summer. I don't think I need to remind anybody about the Stewart debacle and, how sheer greed has closed a number of Massachusetts hospitals and put care in bad shape. Drugstore deserts where people living in large segments of our state, cannot easily get their prescription medications because the drugstores they used to use have all been closed down. And then again, good old United Healthcare, the 800-pound gorilla that is the biggest purveyor of health insurance in the country, is also one of the biggest employers of physicians in the country, who's the killing of whose CEO, while it wouldn't accomplish anything, certainly touched the raw nerve. I think everybody sort of remembers how the man who did it became almost an instant folk hero. Okay, this graph, if I could summarize my whole talk in one graph, this would be pretty much it. Bottom line, you have expenditures per capita on healthcare. And on the other axis, you have life expectancy at birth, which is sort of a surrogate for the quality overall of a nation's healthcare system. And you can see that, it's pretty much follows a nice curve. The more money you spend, the better your healthcare within reason. And we have a good old US of A, who are totally off the curve because we spend a fortune on healthcare and our outcomes are mediocre at best. We are a major outlier compared to the rest of the Western world. I'll refer often as a comparator to the OECD, which is the Organization for Economic Cooperation and Development, a sort of informal gathering of the economically advanced countries, most of Europe, Australia, Canada, Japan, South Korea, countries that are, in a similar economic state as we are. And so, have similar resources. We are spending almost 18-19% of our gross domestic product on healthcare, $14,000 per person. Other countries in Western Europe are spending well under half of that. And at the same time, they are getting better results. The average cost of healthcare for a family in Massachusetts in 23 was over $29,000. Our healthcare is pretty good, but it is also much too expensive. This compares the rise in cost of living generally, and the red one is medicine, starting about 1960. And they stayed sort of parallel until about 1980, when they began to diverge dramatically. Cost of healthcare went up much faster than the overall cost of living, and this has continued. This is taking the numbers up to the present, and again, you can see that the overall cost price, the inflation has gone up. Nobody in this room expects to pay 50 cents a gallon for gasoline, but when you look at the cost of healthcare, it has greatly outstripped the overall price growth. All right, somebody might say, well, that's because we're a rich country, we can afford it, and we have just absolutely wonderful healthcare, and it's worth paying for. To which my answer is unprintable. There are ladies present. Are we getting good value for our money? Again, as I said, life expectancy is sort of the surrogate for overall health care, and our life expectancy is significantly below that of most of our comparator countries. One that an interesting, a little outdated, but probably not any different in 2025, but there was a Time magazine had a whole issue devoted to Cuba back a decade or so ago. And they pointed out that a child born in Havana had a better chance of making it to age 2 than a child born in the United States. Pretty embarrassing. As I'll get into later, some of our results are not all the results of the healthcare system. It's the results of our habits, good and bad, and some of our social behaviors. But one thing that should be under pretty tight control by the medical care system is maternal mortality. Ideally, a woman should never die giving childbirth. And in reality, that's never going to get down to 0. But there are countries, in Japan, it's 4 per 100,000 live births, Italy, 2.5, Australia, 2. Iceland, I think, is the best. They're down around 1.5. The US, it's 26. I mean, we are in that sphere, we are much closer to Zambia than we are to the OECD countries. And this is, again, something of which our country should be embarrassed. The one place where you can chant USA, we're number one, is poverty. This is somebody went around and surveyed people in other countries to ask them, would they like to trade their system for the American system? And even in places where they're not happy with their healthcare system, and Britain right now is one of those, nobody wanted to switch to a US system. And one reason is that, in this country where we still, even after Obamacare, have, tens of millions of people with no health insurance, an awful lot of people who have insurance are just one bad event away from not being able to pay for it. A few years ago, that 1 out of 5 Americans had a medical debt collection on their credit score. About half of all the collection items that are sent out are for medical debt. And, there are a number of people whose mortgages and whose auto loans cost more because they couldn't afford to pay all their medical bills. And so they get dinged. And this has very real practical consequences for, how people deal with the system. Not a great slide, but I'll point out that if we have the pink are overall and the red are people who have a collection item of debt. How many people did not go to see a doctor because they worried about it costing too much money? Almost half of all Americans, 2/3 of those who had medical debt, put off getting health care they needed. 43% overall, 2/3 of those who had debt on there. People who didn't fill a prescription or tried to, use the same pills, just not take enough of them. So these are all very practical things that do impact people's health. We don't overuse medical care. That's not why it's so expensive. Europeans go to see a doctor much more often than we do. Europeans are hospitalized more than we do. They use health spas a lot more than we do. They simply don't pay as much as we do for all of these services. One reason costs are going up is, the U.S. is getting older. We're evident of that in this room. And as we get older, we need more health care. But the same is true in Japan, the same is true in Western Europe, and they don't have the same cost issue that we do. Let's look at some few specifics. CAT scan of your spine. We had a friend who was having some back trouble. He happened to be in Nice, went into an imaging center, had a CAT scan, paid for it out of pocket. It was $200. Same test, same equipment, same everything. In the US is 7 times as much. Hip replacement. Another acquaintance of ours were in Paris. She unfortunately slipped on some stairs, broke her hip, went into a very good hospital in Paris, had the hip replaced, came back and was told by her doctor here that they'd done a beautiful job. And the entire cost, including much better meals, was $8,200. In this country, $38,000. So again, for some very, very similar, essentially identical procedure. MRI of the brain, the average cost in France is $481. The price of one done last year through Mass General here in Boston, $4,000. Again, we're talking same equipment, same everything. The only thing different is the price. The other area where we spend a huge amount of money is pushing paper around. Now, it is, it's not a simple thing. My family live up in Canada, and, my son who's had to deal with all kinds of bureaucracies and, prior authorizations and co-pays and all the rest of it, was talking to his cousin in Toronto. And what happened? Well, when I go to the doctor, I just show him my card and that's it. And I walk out. Amazing. The employment here is growing very rapidly, but it's growing in the field of paper pushers. 25% of what we spend on so-called healthcare in this country does not go to doctors, nurses, technicians, medicines. It goes to administrative overhead. About half of that directly to health insurance companies, and about half of it is the cost to hospitals and doctors of doing the billing, doing the collection, and complying with the numerous mandates that insurers put on them. If you want to get rich in healthcare, become the CEO of an insurance company. That's the way to get rich. United Healthcare, they've taken a bit of a hit very recently, but their first quarter profits were $6.3 billion. And for the simple act of taking money from one pocket and putting it in another pocket. This is not rocket science. This is not creating anything of great value. It is simply moving money around, and they make a huge amount of that on their own. The highest paid individuals in healthcare by far are the CEOs of the different health insurance companies. So one example of the administrative waste I like to point out, being a Montrealer, is that Duke University Hospital, very good university hospital down south, employs 1,500 people in their billing department. The Montreal General Hospital, which is a comparable academic hospital, similar size, employs 10. 10. So, all of those hardworking folks at Duke all get the salary. None of them work for nothing. And that all comes out of your insurance dollar. Health insurance for more and more people in this country is really becoming, it's covering less and it's costing more. The average annual premium for a single person in a small firm was $7,500 a year or so ago. In a very large firm, and they can negotiate better deals, it was $6,800. Family plan was $24,000. And if you're an employer, and if you think of U.S. competitiveness around the world, this is a cost that has to be built into the product you sell. If you are making widgets in Kansas, you have to pay, $24,000 per employee for healthcare. Your competitor in Sweden doesn't. And so it's no wonder they can produce a similar product at a lower cost. One of the things that's happening as the health premiums have gone up and up and up is that employers are fighting back by increasing deductibles. And so, this means in many cases, people who have employer-paid health insurance don't get health care because they can't afford the deductibles. If you're getting by at a minimum wage and you know that you've got to pay the first, $8,000 before your insurance kicks in, you start avoiding health care. So even if you are insured, it may not be usable. Yeah, if you can't read it in the back, good news, I think we've come up with a diagnosis in your price range. I would like to show you graphically what the administrative burden looks like in hospitals, assuming this works. Can anybody hear this?
No.
Uh, all right. Well, if you can't hear it, I'm just going to skip forward. It's basically introducing all of the players in the so-called C-suite, and all of whom get big salaries. At the same time, the CEO says that they've got nurses outside picketing, looking for better salaries and better staffing ratios, and they would do it, but they just can't afford it. Okay, hospitals waste enormous amounts of money. You all learn, in your elementary business school that there are economies of scale. That as you get, and it is certainly true that if you are manufacturing a product, you can get economies of scale. You can run 2 shifts instead of 3, instead of 1, or 3 shifts instead of 2, get a lot more out of your fixed costs, make a product for less and less. It does not work in healthcare. The ultimate unit of transaction in healthcare is a patient on one side and a nurse and or a doctor on the other. And you cannot make that by doing it more and more. You are not going to make it more cost effective. You are, if you're used to going into some of our Boston hospitals these days, finding out that, yeah, you're getting seen faster. Your appointment that used to be 20 minutes now has to be 15, but that's not increased efficiency. Hospitals mark up all of their products. Again, if you ever come out of the hospital and get an itemized bill, you'll discover that every time somebody gave you a Tylenol or an aspirin, there was a $5 charge. One enterprising reporter for the Wall Street Journal who had a hip replaced saw that he was charged at $26,000, and he went to the trouble of getting through the barriers and found out what the hospital paid for it, and it was $1,500. So one of the problems when you get into a major center like New York or Boston is that every hospital wants to do everything. That you can't have another hospital across town doing some obscure surgery and being there better than you, so they will also set up a program. So what happens is you end up with 8 hospitals doing a small number of a procedure as opposed to one doing a lot of them. And we know, and this has been repeatedly showed in almost every surgical discipline, the more of something you do, the better you get. And we really would be much better off to centralize care. But again, you would offend somebody's sense of their own superiority. One of the unfortunate things that is happening more and more as doctors are finding it impossible to fight the bureaucracy is they are selling their practices primarily to hospitals. And the first thing that happens is the prices go dramatically up. If you go to see a doctor at the Beth Israel or MGH, you get a doctor's bill and you get a facility bill. So, you now taken, a bill that used to be charged at $300 and is now charged at $1,200 for the simple matter that the doctor now works for the hospital. And one simple example of this in our community when I was practicing in Framingham, we had doctors who did echocardiograms in their office, and they ended up charging $800. 1 week later, the name on the door announces Dr. X, Metro West Medical Center. Same study, same technician, same equipment, same everything. It was now charged at $1,900. So, again, a large profit margin built in for the hospital. Emergency department. When do you need to go to the emergency department? You need to go to the emergency department if you are seriously ill. If you are having trouble breathing, if you are vomiting blood, if you have terrible chest pain, yes, call 911 and get into the hospital. That's where you belong. If you have a sore throat, if you have a backache, if you have a fever, you do not belong in the emergency department. The doctors who see you there don't know you from Adam, and they will over-test for everything. You'll end up with all kinds of tests that a doctor who knows you wouldn't do. Bills are routinely inflated. I had a wonderful personal example of that. My younger son developed some chest symptoms. I got an x-ray locally down here. He had what's called a pneumothorax. There was air outside of the lung. And so I called a chest surgeon I knew, and he said, bring him into the hospital, bring him into the emergency room. I'll see him. I'll take care of him. And we brought him in, and the surgeon met him. The surgeon took care of him, put a chest tube in. The emergency physician at one point stuck his head in and said, hey, how are you feeling? Well, I'm kind of sore. I'll get you something for that. And he got a pain pill. And that was the total. I was there the whole time. So I know that was the sum of the interaction. We then got a bill from the emergency physician group for comprehensive medical evaluation and treatment. So, that one, at least I knew enough to call and say, hey, this is fraud. Oh, we'll reduce it. But if you don't know enough, you may end up getting done for the bill. The other thing, which is a little less of a problem since some of the new legislation, but a lot of physicians who know that you're not going to choose them will opt out of your insurance. So you may go into a hospital that you know is on your plan and then discover that the anesthesiologist who put you to sleep with the surgery, the emergency physician who saw you, the pathologist who looked at the sample are all out of network and so can charge whatever they feel like charging. Cost for evaluation and management claim. You've got physician offices, you've got urgent care centers, and then you've got the ED, where you've got both the professional fee and the facility fee. And you can see, looking back over the last couple of decades, what's happened to those. And so again, if you are really sick, yes, but if you're not really sick, look for an alternative. Look for an urgent care center. Try your doctor's office if it's when they're open. A good functioning healthcare system should have roughly 50-50 primary care physicians and specialists of all sorts. And through most of the Western world, this is about what you see. In the US, we're about 75% specialists, 25% primary care physicians. And it's going to get worse. I mean, primary care physicians justifiably feel they do much more work than specialists and they get paid much less. And medical students, not being dumb, will go where they can have a better lifestyle and make more money. So, why be a general internist when you can be a dermatologist and work 4 days a week and make double the amount that the general internist does? So, if you are trying to find a primary care doctor, and I know it's an issue down on the Cape, it is tough. When I closed my office and I was trying to get people hooked up with a new doctor, I had to call in every chit, anybody I'd ever mentored, anybody who owed me a favor. And even then I couldn't get primary care doctors for all of my patients. So, it is hard. One of the reasons that it impacts the cost of care is that, as the old saying goes, if the tool that you have is a hammer, everything looks like a nail. And if you are, say, a gastroenterologist who knows that he can get several $1,000s for putting a tube into one of your openings, he's going to be really inclined to do it. You go to a good primary care doctor and say, I've been having some heartburn for the last few weeks. There are nothing particularly worrisome. My appetite's fine, my weight's fine. Then he'll say, okay, you've probably got a little bit of acid reflux. I'll give you some medication. If it doesn't cure the problem in the next month, get back to me and we'll look a little further. Take the same complaint to a gastroenterologist and he'll say, well, we should take a look down there and see what's going on. And he takes a look down there and hopefully you're in the 99% where it goes well, not the 1% where there's a serious complication. And when you wake up, he says, well, you've got some excess acid. I'm going to give you some pills and it'll make it better. Same treatment, same result, just a very expensive way station. I'm sure most people saw the news recently, executive order that's going to be utterly useless, but is supposedly going to cut our pharmaceutical costs. We need something done, and we need something done very badly and very soon. We are spending a huge amount of money on medications that are costing about half or less that anywhere else, literally anywhere else in the entire world. I looked up average wholesale prices of a few commonly used medications, and you can see, basically anywhere from 10-fold up the price for the identical pill from the identical manufacturer in the U.S. as in Canada. So yes, we do need to bring those prices down. I don't know if you're familiar with the cost plus pharmacy. Mark Cuban, an entrepreneur, teamed up with a doctor on the West Coast, and they are supplying a huge variety of medications for their cost plus a delivery charge plus a set markup. And, Mark Cuban is not doing this out of his pocket. He's making money at it. And yet you look at the difference, doxycycline, which is if you happen to get, unfortunately, bit by a tick here on the Cape and end up with Lyme disease, doxycycline is the medicine of choice. And if you go into a retail pharmacy, the charge is $800 plus. Mark Cuban will sell it to you delivered to your door for $16. So, and a variety of other medications that are similar. Somebody did a calculation. Medicare could have, saved through almost $4 billion a couple of years ago if they'd bought their generic drugs from Mark Cuban instead of having people go to the pharmacy. Anybody, the name Martin Scregley ring any bells to anybody? The pharma bro. Toxoplasmosis is a serious infection that's very rare. Fortunately, it tends to hit pregnant women, people with immune deficiencies. Untreated, it's commonly fatal. And there's only one treatment for it, a drug called Daraprim. And that was pretty expensive. It was $13 a pill. And then Martin Scregley said, this is a monopoly situation and monopolists can really get rich. And he bought the company that made the medication and he raised the price from $13 a pill to $750 a pill. He was called to Washington. He was brought in front of various committees and he didn't do a thing. He said, that's my price. And, since when you have this infection, you need that pill or you die, well, you pay $750 a pill. There is some justice in the world. Scregley later went to jail, not for this, but because of stock manipulation. And probably what disheartened me most of all was an interview that I saw with an entrepreneur who was asked about this, and he said, well, Martin's only obligation was to his shareholders, so I think he did the right thing. I'll let you decide whether he did the right thing or not. Pharmaceutical companies are not our friends, much as they would like to convince you that they are. They do an awful lot to increase the demand for their products. More and more normal variants in human behavior are getting labeled as diseases, for which the pharmaceutical company happens to have a remedy, of course. There are only 2 countries in the whole world that allow direct-to-consumer advertising. The other one, oddly enough, being New Zealand. I don't know how that got in there. But, you are all familiar with pharmaceutical ads. They're very stereotyped. You start off in black and white, and somebody is really unhappy, and they're going to miss their grandson's graduation. And then the magic pill comes in, and all of a sudden, just like Wizard of Oz, you're going to glorious Technicolor, and everybody is happy and lives well ever after. And the interesting thing is the less clinical benefit a drug has, the more that is spent on advertising it. Maybe not surprising and certainly not dumb. Doctors get visited regularly by detail people. When I started, and most doctors were male, these were all attractive young women. Now that we're more 50-50, there are now attractive young women and attractive young men who call on the doctors. And they will bring lunch for the staff and, in return for you giving them 10 minutes to listen to a sales pitch. Doctors will all say, well, that goes in one ear and out the other. I don't listen to sales pitches, but I like to have a free lunch for my staff. Again, baloney. There was a beautiful study which tracked numbers of visits by a detail person and prescriptions written, and it was linear. The more often you had your free lunch, the more you prescribed the drug brought to your attention by this nice person. Opinion leaders, the people who write guidelines that doctors are supposed to follow, people who speak at national meetings, almost to a person have pharmaceutical money behind them. Either the big pharma is supporting their lab, or it's giving them very handsome speaking fees to travel around the country and speak. And so they're not going to bite the hand that feeds them. So we get it from all sides. If you look at a bottle of pills, invariably it'll say, do not use after such and such a date. Ignore that. The U.S. Army, when they were worried about what would happen in a major conflict, they took a whole raft of pills, buried them out in the Midwest underground, picked them up 3 years later, assayed them, and they were all fine. So, those expiration dates are totally arbitrary. And unless it's crumbling or unless you've, kept it in a sauna bath, you can use them well after that date. Pharmacy benefit managers. I think that is another thing that is unique to the US of A. The pharmacy benefit manager is the person who organizes what pills you can get and how much, and they do this on behalf of the insurance company. They negotiate prices, they theoretically cut the price, and they keep a large portion of the savings for themselves. And the sort of thing that you wouldn't believe. I mean, it almost sounds as if it's, I'm making this up, but I am not. There's a very expensive drug called Humira that's used for rheumatoid arthritis, among other things. And it's very, very expensive. It costs $90,000 a year for Humira. A couple of years ago, Amgen came out with what's called a biosimilar. It's not exactly the same, but it is very close to the same, and it does the same thing. And so how are they going to price it? Well, you could buy this new drug at one of 2 prices. You could buy it at $85,000 a year, a little bit under the established one, or you could buy it at $40,000 a year. Okay. Who on earth would want to buy something for 85,000 rather than 40,000? I mean, logically, it makes no sense. Well, the PBMs love that because they started with the 85,000 price. They quote negotiated it down to 50,000 and then claimed half of the savings for themselves. Again, does it make sense? Not only in a very bizarre world, but we are living in such a world. I don't know. I'm sure you all got this issue, whether you remember it or not, of Tech Review from let's see what year was that anyway. And this is a whole new problem that we have yet to come to grips with, which is that we are getting marvelous, marvelous drugs at marvelous, marvelous prices. We're getting these new drugs coming out quite often, and they are typically genetic engineering drugs. They are drugs that can treat conditions that up until now were totally untreatable. You can take a hereditary disease, you can take something like sickle cell anemia, and you can cure it. And this is absolutely marvelous. It is, it is a real triumph of current science. The problem is all of these have a very short track record. And the issue is, yes, if you can cure sickle cell anemia, a disease that has people go into the hospital 2-3 times a year, get all kinds of infusions, and they're going to do this for decades. If you can cure it, then it's probably worth $1 million. But what happens if it doesn't? What happens if this only works for 2 years or 3 years? And, the insurance companies are balking at paying for it because we all change insurance every few years. So Blue Cross will say, why should I pay $1 million for this when I know that the odds are in 2 years they're going to be insured with Aetna? So, it's not fair for us to pay it. And we need to, as a society, come up with a rational and fair way to pay for these things, assuming that they work. Switching gears a little bit, this is a subject that's near and dear to my heart. I've been involved for many years with several national organizations that are trying to reduce the rate of misdiagnosis. But a publication came out 10 years ago from National Academy of Medicine, in which they looked at all the available data and estimated that 5% of the time a doctor's visit resulted in an erroneous diagnosis. In some cases, it really doesn't matter if somebody says you've got, a strep throat, and you really have a viral sore throat. It's not a big deal. But if there are many others where, in fact, it is an extremely big deal, and you get either miss important treatment or get the wrong treatment. And we've known this for 100 years. Autopsy studies going back to the Europe in the 1900 or the Cabot cases at Mass General in the early part of the latter part of the 19th century showed that about 10% of autopsies of people who die in hospital show important diseases that were never picked up during life. And there are a lot of reasons for this. It can be partly, patient may withhold important information. Doctor could miss important physical exam finding. Lab test might get lost. An X-ray could be misinterpreted. But the single commonest cause is simply the doctor never thought of it. There's good data showing that doctors tend to make diagnoses with what it's called system one thinking, immediate pattern recognition. Oh, I've seen this before. This is what it is. And rarely do they stop and, think through logically. And the single most important thing I tell people who want to avoid a diagnostic error is no matter how obvious it is, ask yourself, what else could it be? After a nice meal with a high-calorie dessert, I'll have to indicate that, in fact, the healthcare system is not the only problem with our healthcare. All of us have to take a certain active role in our own health. Diet, not smoking, not drinking excessively, exercising regularly, keeping your weight down. If you do these things, you're going to do more than 90% of the pills on the market. There was a very good study that came out a while back looking at the average 50-year-old woman who scored 5 out of 5 on these 5 good habits would live 14 years longer than one who has scored a 0. For a man, 12 years longer. So an awful lot of our health outcome depends on not what the doctor does, but what we do. Looked at another way, this is adding to those healthy, to the good habits: smoking, weight, adequate sleep, good diet. You put in a few lab tests, and again, if you have score very well, you're going to live a whole lot longer than if you do badly. You can get a 63% reduction in mortality from doing all those good things. And if you have a high cholesterol, treat it, bring it down. If your blood pressure is high, get it under control. These are problems universally in the sort of developed world. One that's kind of unique to the U.S. is some of our social habits. Guns, drugs, cars. U.S. teens have a much, much higher death rate than teens in Europe, and it is primarily because of gun shots. Overdoses, we had, during the worst of the time after the pandemic, we had over 100,000 deaths of despair, deaths from drug overdose. A couple of years ago, there were 47,000 deaths from firearms. I hope I'm not offending any gun owners in the audience, but I do not think any civilian has any business owning a handgun or any rapid fire weapon, and we would save a huge number of lives. Massachusetts isn't too bad. We've got one among the stricter gun laws, and if you compare our death rates from gunshots with New Hampshire, we are quite a bit lower because our laws are stricter. Overdose death rates. I suspect some of the ones in the top are underreported, some of those countries, but countries that do report well: Switzerland, Germany, Netherlands, Spain. You're looking at maybe 15, 20 per million population. U.S. 324. Wow. I mean, that is, if that isn't a dramatic statistic, I don't know what statistic I can show you is. France, 9 people per 100 million die of overdoses. In the U.S., 324. That is Puerto Rico, so kind of part of the U.S. Scotland seems to have trouble. Canada, Wales, Iceland, they get a little depressed there with Sweden with all their long winters. But again, they all pale in comparison to the U.S. How do we fix our healthcare problems? And I wasn't sure at the time, but Bernie was right. The best solution really would be single payer healthcare, Medicare for all. Obamacare has done a lot of good things, but it was tinkering at the edges. The reason that finally that Affordable Care Act got passed is that nobody's ox was getting gored. The hospitals liked it because they would have more paying customers. Doctors like it because they'd have more paying customers. Insurance companies loved it because they'd have more people to insure. So all the big money players in the system were essentially on board with it. And so we got the Affordable Care Act passed, but it was not socialized medicine or anything even close to it. It was basically tinkering at the edges. You know, it's nice to have let your kids stay on your plan until 26 instead of 18. It is certainly very nice to not have to worry about caps on total spending if you get some really bad disease, but it's not going to change the system. It will never lower costs. Single payer could give everybody access to basic necessary health care. We are not a socialist country, we're a capitalist country, and if people want to pay more, God bless them. You know, even in Canada, which does have single payer system, you can buy supplemental insurance so that if you go in the hospital, you can have a single room, or you can have, elective plastic surgery, which may not be covered under the national plan. But nobody will go without insulin if they have diabetes. Nobody will not be able to have their appendix out if they have appendicitis. So, we need that. It would be extremely cost effective. As I started off, we're about 25% of our spending is going to administrative costs, and that could be dramatically lowered if we were to bring it down. Medicare pays under 2% for its overhead. Contrast that with the 15% that a commercial insurer gets. If you had a central purchaser, you could align value with price and get more reasonable prices. The only caveat in this system is you adequately fund it. The problem in the United Kingdom is not that the National Health Service is a bad idea. The problem is the politicians have starved it. They've looked to cut money when they didn't want to raise taxes or wanted to put it elsewhere. Given the logjam in Congress, realistically, we are not going to get the National Health Service through, and certainly in my lifetime. But there are things that are realistic if we get some pressure. Gradually expanding Medicare would not be as threatening. Maybe in letting people sign on at 62 instead of 65, and maybe after a little longer, bring it down to 60. Let the small employers who are currently getting raked for cost of insurance to sign on as Medicare. We've made a start at getting the government to negotiate drug prices. That needs to be expanded. There's absolutely no reason at all why we should subsidize the rest of the world and let the pharmaceutical companies get rich. There's also a lot that can be done at the state level where we have more direct contact with our legislators. I've never once laid eyes on Senator Markey or Senator Warren, but I have many times spoken to my local state rep and senator, and we can all have a little more influence there, I think, than we would at the federal level. Get better oversight by the state on mergers, acquisitions, keep private equity out, make them, jump through so many hoops that they won't be able to get that high. There are a lot of things you can do as individuals for your own health and your own costs. I am going to offer to let you buy my little book at the end. If my gorgeous assistant, also my wife, will be happy to sell you a copy. And share it with friends. Ask for change. We are not going to get change if we just say, well, this is the way it is, and there's nothing I can do about it. When I was a kid, we drove down from Montreal to Florida over one July 4th weekend. And having never been out of Canada, first stop we got to Virginia, the first thing that almost floored me was getting out of the car and seeing a sign that said whites only. We're not in Nirvana yet, but we are, at least we've gotten away from bathrooms that are segregated. And that was because the people demanded it. And we can do the same thing if we really demand it. When your rep has open meetings, ask them what they're doing. What are they doing to lower drug costs here? What are they doing to keep the next Stewart from happening? Why is our maternal death rate in this medical mecca so high? So make them commit. Prescription drugs, when you're getting a new drug and it's brand name, ask your doctor if there is a similar drug that's available generically. You will save a fortune. Look at the Mark Cuban Cost Plus Pharmacy. Can save you a ton of money. Go to things like GoodRx and get coupons to get your drug costs down. There are a lot of things that can be done right now to saves a lot of money on your prescriptions. If you want to do research on your own, please don't go to Facebook. When I heard our esteemed Secretary of HEW say that parents should do their own research on vaccines for kids, that was the image that came to mind, is somebody whipping over to Facebook, that hotbed of misinformation. Go to trusted sites. All of the major hospitals have, pretty good information. Mayo Clinic, Cleveland Clinic, Harvard, they all have a lot of fairly reliable information where you can get good data. The National Library of Medicine will let you, if you really want to get into depth, that is open to anybody. It's obviously aimed at doctors, but anybody who wants to can go on there and look up good information, but to get it from a vetted source. When you go to the doctor, these days, unfortunately, unless you're in a concierge practice, your doctor is under the gun and is going to be not giving you the time that they should. Don't go into a visit without a plan of how you want to get something out of that visit. I can tell you, having been there, that when you see somebody for what is expected to be a, quote, routine follow-up for their blood pressure or their diabetes, and you're wishing them well and you've written prescriptions, you've got your hand on the doorknob, and they say, oh, by the way, doc, I didn't tell you about this horrible chest pain I've been getting. All right, what do? I'm not going to walk out the door. That means everybody else the rest of the day is going to be swearing at me for being late. So if you have an important complaint that you really want to get taken care of, you walk in and you say, I know this was a scheduled visit for my diabetes, but I've been dealing with this really horrible, whatever it is. So can we talk about that first? Okay. People tend to lose their cool. They, forget what it was. So bring notes. If there's something that's important, write it down, bring it with you, look at it before you start the conversation. Take notes. If you don't feel comfortable doing it, go with somebody who can be a second set of ears and maybe take notes for you. It's been amply proven that about 3/4 of what the doctor said to you is totally gone by the time you get to your car. So take notes. The only dumb question you can have for a doctor's visit is the one you should have asked but didn't. There are no dumb questions. There's also the phenomenon that doctors tend to talk doctor speak, which doesn't always translate into English. And so, if you don't understand something, say so. Yeah. Or would you mind saying that a different way? I'm not sure I fully understood it. In an ideal medical encounter, the doctor would say, okay, summarize what you think I've said and what our plan is. And then they can see whether you did get it. That doesn't happen nearly often enough, but again, leave the onus on you to actually ask the question. As I said earlier, doctors are human, doctors make mistakes, doctors miss diagnoses. And again, if you get a new serious diagnosis, say, okay, I understand that's what you think, doctor, but could it be something else? They should ask themselves that. If they don't, you ask them, what else could it be? And if it's a really serious diagnosis, or if a serious therapy or surgery is being recommended, get a second opinion. Two heads are definitely better than one. Mayo Clinic did a report a few years back. They looked at everybody who came to Mayo for another opinion, and about 20% of the time, the patient left with a completely different diagnosis. And in about 60%, it was more sort of the same, but it was refined or clarified. So, it's again, a doctor should never be insulted by your saying, could I get another opinion? If they are insulted, get another doctor. As we get on in years, all of us should have a healthcare proxy, should have somebody who can make decisions for you, should specify your wishes, or what you would like done if you are in extremis. Don't make people guess. Don't have, as happened to me all too often, somebody in the intensive care unit, we all knew they were not going to make it. The 3 kids who were local said, yes, let's make father comfortable. That's what he would want. And then, the 4th child flies in from the West Coast, who hasn't seen them in 10 years. And you do everything possible for father. If he dies, I'm going to sue you. So, make sure that everybody knows where you are on that spectrum. Okay, I think I've covered what I wanted. Hopefully we have some time for comments and questions. Yes, sir.
I assume that Cape Cod Healthcare is a nonprofit, since they ask for donations, and Ford Motor Company doesn't ask for donations. If that's true, is there an opportunity for a group of potential donors to go treat them as if we're investors, and that they shouldn't be doing these wasteful things, if in fact they are?
The difference between nonprofit and for-profit hospitals is not nearly as great as you would think it is. The big difference is that nonprofits don't talk about profit, they talk about retained earnings. But in fact, all hospitals are required to provide a certain amount of free care, charity care, and the for-profit hospitals in this country give slightly more than the non-profits. So yes, you certainly can approach the board of every hospital, every nonprofit has a board of directors who are supposed to oversee and help set broad policy. In all too many cases, I think they are simply, they listen to the CEO. In many cases, they're very talented individuals, but with very little, healthcare background, and they tend to sort of accept what the CEO tells them. But yes, it's a local nonprofit. Ask if you can get on an advisory board. Ask, say you're interested in potentially serving on the governing board. and make your voice heard. Definitely. Yes.
In your title, you address bankruptcy, and then you talk about how almost half the people have a medical debt can you hear me okay?
Sort of.
Oh, okay, have a medical debt on their records, and several decades ago, I represented a young family of four, where they had a new baby, and the baby had some major health issues, and they had these exorbitant medical debts. And under Chapter 7, they were able to get a fresh start. The Bankruptcy Act was then modified to make it very difficult to do that. And instead you had to resort to the Chapter 13 long-term options, which basically no one can complete. If people could discharge their debts in bankruptcy, what would be the impact on the healthcare system?
An awful lot of the bad debts that hospitals deal with getting sold to debt collectors at, pennies on the dollar. And, it would make a whole lot more sense for the hospital simply to write those off, because they're not getting a whole lot of money from it. It's the debt collectors that tend to get most of the money. There's a national charity that will pay off medical debts for people. You can, at worst comes to worst, you can declare bankruptcy and your debts are gone. But then, of course, it takes you years to dig out a credit score back recover from that. But the other thing is people need to go to the hospital and say, I know you're required to provide charity care. Am I eligible for that? If you have a large family and low income, you are probably eligible for free care, but they may not offer it if you don't ask for it.
Yes, sir.
Are there instances where private equity taking over hospitals has actually been successful, unlike Stewart? And if so, how did that work and what Stewart didn't work?
The question was if there have been examples of private equity taking over hospitals where it worked. I'm sure there are. There's a huge literature now looking at what happens when private equity comes in, and the overall is negative. The model of private equity is you come in, you get as much money as you can out as quickly as you can, and you turn it over. And that may work fine for a restaurant or a factory. It does not work for a hospital. Stewart was particularly egregious in that they loaded up the hospitals with these obscene deals to pay for essentially rent. They sold the plant and the grounds to a real estate investment trust, and then turned around and charged ridiculous amounts to the hospital. But the overall is when private equity takes over a hospital, mortality rates go up a little bit, surgical complication rates go up a little bit, quality scores go down a little bit. I'm sure there are exceptions, but the overall trend is clearly more cost and poorer care.
Yes, sir.
I have to follow the logic of the lecture. It starts with presenting the problems, presenting the high cost, method to reduce it, and then an alternative. The major missing link here that I assume everybody here has Medicare, most of supplementary insurance, and we don't see that. So you may see a bill of $80,000 of surgery, then you see Medicare approved $6,000, at the end of the day you have to pay $0. So it is a missing link here. It is logical from a national point of view and everything, but on a personal basis, there is the missing link.
Particularly if you have traditional Medicare and a good supplement, you're in a pretty good place. One of the difficult issues is that over half of all all Medicare recipients now belong to a Medicare Advantage plan. And Medicare Advantage plans are starting to turn the screws on things like prior authorizations. They make you go through step care to get a drug your doctor says you need. And so, they are oversold and underperforming. If you have traditional Medicare and you have a decent supplement, you're in a good place and you don't have to worry about a thing.
Many of the results you showed, disparity of outcomes from us to other countries, really fall on the shoulders of poor people. If you have Medicare with a good supplemental, you're not really affected by it. Your costs are affected, but you can afford it. To reverse that, I think, would lead to people screaming about socialized medicine because you're paying for poor people. How do you see that being effective?
Yeah, I mean, this is a philosophical question. The question ultimately comes down to, do you believe that healthcare is a right or an optional, something that people can get if they deserve it or can afford it? I happen to believe that basic healthcare is a basic human right, and that, we are a very rich country, and there's absolutely no excuse for the way we do business in healthcare. But that is, just as, I may be out of step with the majority on guns, I may be out of step with the majority on the fact that healthcare should be a basic human right. I don't know. I mean, one of the things that I've heard from colleagues is that eventually this whole system is going to collapse because it's just become so expensive we can't afford it, and everything will collapse, and then will I get a chance to build up again new? I hope it doesn't get to that, but it wouldn't shock me.
Yes, hello. One of your slides showed the operation of a hip replacement, and dramatic difference from what a foreign country pays for hip replacement to us. Now, it's labor intensive. It must take so many hours to do it. How is it so different? Is it because of all this loaded up extra cost? I mean, the surgeon doing it doesn't spend any more hours. Doesn't he get paid about the same?
The surgeons in Europe do not earn as much as surgeons in America do. They probably, again, the disparity between primary care and specialty care that's universal. A French surgeon will make more than a French family doctor, but they don't make as much as an American surgeon does. A lot of it is, if you go to MGH, you have probably 100 people in the C-suite, all of the vice presidents and assistants to the vice presidents and all that, all of which are added to the cost of of hospital care, even though they're not doing any care. You don't get that in European hospitals. Now, in insurance, that's, again, one of the, Mass General Brigham, which has been my home for most of my professional life, unfortunately, is in a position where they can essentially tell insurers, this is what we're going to charge. It would be very difficult to sell health insurance to a Boston company if Mass General and Brigham and Newton Wellesley were all excluded. They are, the prestige hospital in the area. And so they, in essence, get to dictate what they're going to charge. And the insurance company ups their rates to cover that. All right. Thank you all very much for your attention. Oh, I turned it off.
Thank you very much. This is a perhaps sobering lunchtime for us all, but something we all need to listen to. And as a final parting gift, it's our standard offering to our speakers, a pair of stemless MIT Public Cape Cod wine glasses, which should not be filled with alcohol.
Thank you very much.